Hello.
Torie, good.
Hi,
Hi,
Rohit.
how are you?
How's it going?
I'm very well. How are you?
I'm good, thanks. I've been going now 10 hours, almost
Oh
straight,
my,
the interview.
you must have lost touch with your real self. You might not be knowing who your virtual self is and where your real self is.
Yeah, thanks. Yeah, see, I can't even challenge that. I can't move on saying.
That's
Those are
great.
two six.
Any gook I say now is going to be just taken
Yeah,
up.
I'm just connecting to the Epilepsy Sparks Live, 2 secs. Thanks so much for doing this. I just had Maxine Smeaton on. Did you see that one?
No, I mean, I've been sort of, today's all been kids. It's
Oh.
all been kids. So it's from since today morning. They are really pleased that I'm out of their hair now.
You always make me laugh. Oh my goodness. And do you know what? Sorry, go on.
It ends up with me usually being critical of their bedrooms, about their this thing, stuff lying around. Why is this there? And what are you watching? And it's sort of, I become very, how should I say, intrusive. So I think they are
That's
happy.
a very polite way to put it. How old are they now?
Oh, one's 10 and the other's 4.
Oh, see, 4's okay. 10 is going on the erring towards the dodgy side.
Yeah. Well, he's quite a geek. So I'm not too worried about the 10 one. He's the boy. The girl, she is a bit, let me say, she's sort of 4-year-old and she has already good ideas. I mean, she's got some really interesting ideas and she challenges authority, unlike my son. So
Good on her. Oh my goodness. But it's good to stimulate conversation with your child and encourage questions, right?
yeah.
Right, so we are live, I think. Yes, live, nice. So everybody, please meet Rohit Shankar, MBE award winner, amongst a million other things, neuropsychiatrist. And please, you continue, Rohit, with your, and tell everybody exactly what you do, if you can, like in 30 seconds.
My index of vanity and narcissism. Yeah, I mean, I'm a honorary associate clinical professor at the University of Exeter Medical School and consultant neuropsychiatrist, working usually with people with intellectual disability and neurodevelopmental conditions like autism, where obviously epilepsy is much more pronounced and has a much more significant presentation.
And we were going to talk about SUDEP as well, because we haven't really touched on that with anybody else today. And I know that's something that's one of your passions as well, because you work with SUDEP Action, don't you? And
yes.
It's part of the Epsimon app. Maybe you can tell us about that.
Yeah, I mean, do you just want me to sort of briefly outline SUDEP a bit?
That would be good, yeah, because not everybody knows what it even stands for or that it exists.
So I guess SUDEP is a bit like the situation we are facing with COVID. It sort of gives us a real empathetic value because SUDEP, COVID is there. You or I, Torie, we are both susceptible to degrees to COVID, and there is no obvious solution to it. And SUDEP stands for sudden unexpected death in epilepsy. So the moment you're diagnosed with epilepsy, you carry a particular level of risk to die of epilepsy. But that risk can vary based on various human and social factors, just as COVID in a way, where depending on which group you fall into and things like that, your susceptibility changes. But I think the challenge is that there has been some sort of, how should I say, shyness to discuss about SUDEP. We don't stop shy of discussing COVID. It's written on the face. It's the same sort of thing with epilepsy. I think we need to be discussing risks, and it's well supported by NICE guidelines, the American neurological guidelines. Any top guidelines actually says that the moment epilepsy is diagnosed, people need to talk about sudden unexpected death in epilepsy. The challenge which comes is that it's not that easy because the risk changes over a lifetime, and it depends upon the individual and their course and trajectory of their risk. And where the guidelines don't go far enough is about proposing that the risks get remeasured annually or systematically so that people can take remedial action, at least in factors which are social factors and issues like I'll come to that about certain very key indexes which can actually hopefully mitigate the risk of harm.
Mm-hmm.
The again, just to put in context with regard to SUDEP. So SUDEP, now everyone knows of asthma. Even the person on the street knows of asthma. There are around 5.3 million people with asthma. Tragically, around 1,300 people a year die because of asthma as a primary cause. There are around 600,000 people in the UK with epilepsy, and almost the same number die because of epilepsy as a primary cause. It's a 10 times bigger killer. And research has shown that preventable deaths in epilepsy is around the range of anywhere between 40 to 60%, depending on the study that you take.
Mm.
In asthma, it's around 20 to 25%. So I'm not saying that we should neglect asthma, but I think we need to be giving a fairer treatment to epilepsy and putting it in the same league as other chronic illnesses, which have sudden spiky exacerbations and things.
Mm.
Now, with SUDEP, it's sort of one of the interesting things is that the studies which we have done have shown that there are multiple factors. There is obviously genetic factors which are linked, like things like Dravet syndrome
Yeah.
is some, and luckily it's quite rare, but there is a genetic clear linkage that people who have Dravet's are more pronounced to have SUDEP. So genetic causes play a role, but the single most important factor in SUDEP causing SUDEP is actually something like the generalized seizures. So
Yeah.
anything more than 2 generalized seizures a year increases SUDEP risk by 5 times. 3 increases it by 15 times. And it's not the be all and end all.
No.
We have other factors, and for convenience sake, that's where our work with SUDEP Action has looked at developing a checklist, which has formed the background of EPSMON. So the checklist is for clinicians to use, and where we divide it simply into modifiable and non-modifiable factors at review. It takes 10 minutes to complete, and the
Mm-hmm.
checklist looks at factors where age of onset of epilepsy, sex, the issue with regard to type of epilepsy, which are all usually, these are all not changeable factors, so they are non-modifiable.
Yeah.
And then there are modifiable factors, which interestingly have been linked to, if you can actually change them, the prognosis could be better. I'm not saying it's brilliant, but it can improve and possibly ward off SUDEP, hopefully. These are mainly nocturnal seizures and surveillance. So people who have nocturnal seizures, 70% higher risks are there of encountering SUDEP.
Yeah.
They're obviously, if they're having nocturnal seizures, it makes sense that they get some sort of oversight and support. And simple things like having an audio monitor in the room when there is a change in situation might make a difference. Obviously, it has to be balanced with practicality and intrusiveness and privacy, etc. There is things like alcohol and drugs, again, though not very clearly nailed down, but they tend to increase the number of seizures. So there is a loop there. And the biggie is obviously compliance. People, it's recognized that people, no brainer there, people who are actually, who are dying, there is much more association with poor compliance.
Yeah.
Things like complex epilepsy and treatment changes are linked to it. So we know that there are a host of factors. We know that there are a host of non-modifiable factors. The more epilepsy you have, the more likely you are likely to encounter SUDEP. And the numbers that we are speaking of, it starts really low. I mean, again, the COVID analysis is quite COVID, the comparison is quite
This is
interesting.
such a good
Initially, you don't
comparison. I
worry
like
about it.
it.
And it is sort of, and once you cross 15 years of having treatment-resistant continued seizures,
Yeah.
the risk balloons up to around 42%. So 1 out of 2 people might actually are at higher risk of harm from SUDEP. So that's the sort of things which we talk about. And you have initially, when newly diagnosed, people are at risk of around 1 in 4,000 or something like that. And studies vary between 1 in 4,000 to 1 in 10,000 man hours and people. But as it goes on, say treatment resistance, which is defined as if people are sort of two drugs don't work on them satisfactorily, they fail that or have side effects, the risks tend to escalate. And those who are rejected for, say, surgical interventions, it's one in around 150 to 300.
Do you know what
So
my old neurologist, Tim Vena, who's top guy, he said to me, in these weren't exact words, but he obviously knew he could be blunt with me, and said, Torie, your life expectancy isn't great, like, because I had refractory epilepsy, they were having more and more seizures, more and more accidents, and so my risk of SUDEP was really considerably higher than for, say, the average. And I was so grateful that he said that to me. I actually laughed because he was so blunt. But it's, you know, I think patients deserve to know.
it
Sometimes,
is, and I think the thing is, it's just like if I mean, we all our bodies go through wear and tear in life.
yes,
Some unfortunately more than others. Some unfortunately have conditions which cause that wear and tear. But if you take a car to, I mean, if you have a car which is getting older, and you're sort of, you expect your garage to tell you that, look, the brakes will require replacing in 6 months time, or you are actually you need to take a bit more charge about it, something else will go down, or I mean, you want to know that information. You don't want to be on the motorway and end up having a breakdown. That's not, so why would we want it in our lives? I would like to know what all the potential risk hazards are, most which might be avoidable, some
yes.
which might not be, but for which I can actually plan for and mitigate it by other ways. So lifestyle choices have a huge impact on our on the way in which our prognosis of a chronic condition such as epilepsy.
Exactly. Do you know what one way I've put it before is, like, when you're little and you have maybe one of your parents or whoever it may be teach me how to cross the road, and they say, look both ways, see if you get any cars coming, and listen as well. Say, but you still might get run over, by the way, but you can minimize your risk. And then you learn that, and then as long as you're sensible, you look both ways each time. And that is how you prevent yourself from dying from a car crash. Fingers crossed.
Totally, totally.
Just
But
like that.
I think the problem that's there is that people out there are ignorant because science has moved on. I mean, 10 years ago, there was still a debate about whether we should be talking about SUDEP to patients or not. Nowadays, it's nailed down that we have to talk about it. We are now pushing to say it should be talked about regularly, and also the risk assessment should follow. And it has become part of common culture among my colleagues in neurology and psychiatry and everything. But I think it's still, you've got a lost flock of people who sit in GP land, in primary care land, who have been seen, dealt with, thought to be okay, and discharged. And what we are finding is that there is a whole, it's like an iceberg. We only know about the tip, which gets referred in. What about all the people who are staying away and thinking that they're getting on with life because, oh, a few seizures here or a few seizures there, no big deal sort of thing. And that's where EPSMON comes in. EPSMON is an app which, as you know, Torie, I mean, you've been helping front it, is something which has international recognition. It's won a lot of awards. It's been, SUDEP Action have been partners on it, and they've been brilliant with regard to making sure that EPSMON and the SUDEP checklist gets the airing that it does. But at the end of the day, it is left to individuals to download the app and to risk assess themselves. It only takes 10 minutes. It's a digital version of the SUDEP and seizure checklist. It helps people understand where, it's almost left field. So it will help highlight whether recently, say, if now lots of people have been furloughed, they are sitting at home, they might be drinking more alcohol or seeing more television, or something else might be changing. And these things might have a knock-on effect on their seizures. They might be getting depressed, and they might be getting stressed. And this has a knock-on effect on their mental health, sleep, which then has a knock-on effect on their seizures or their compliance, which they might find it difficult to understand, which their GP, if they go with increased seizures, might find it difficult to understand about all the background. So something like EPSMON would actually capture in 10 minutes all the key indicators, the metrics which are needed, which tend to dial up the risk of SUDEP and seizure harm. And I think just taking that screenshot across to the GP, will make them understand, oh, well, okay, this is not about just the seizures, but you might need counseling for your stress and depression. So,
Yeah.
and it's those little things, because we are not really, none of us are really very far away from the cliff edge of life. It's just sort of sudden. I mean, who anticipated COVID even 3 months ago?
Bill
Nobody.
Gates.
And it like people who I know, people who are in secure jobs, in good jobs in IT world and things, who just got now laid off.
Yeah.
And it's a huge lifestyle thing to not have something to do when you're thinking your career at 50 is secure. You're going to get another 5 years or 10 years, and then think about winding down, and you have this thing which you want to do next. It's sort of just these things come off the
Hits you like a
from the
brick.
time. Yeah. So I think that's where EPSMON, it reminds people every 3 months to update their seizure profiles, gives them, we've had around 3,000 users running it regularly. And
Well, that's
it's,
heaps more than this time last year. That's fantastic, but we need more.
yeah, we need definitely more. There's 597,000 people sitting out there, isn't it? If you do the maths. But
Well,
the
and
way
I swear humans are breeding, so I reckon there's more than that as well. So
and it is sort of something which we are, EPSMON did not, in my view, in our 3,000 people analysis which we published recently, hadn't actually showed it didn't actually show this thing, what you call the problem with it didn't show the solutions, but it actually highlighted the problems that people have. An average of 19 years of epilepsy, they haven't seen their GP. Many of them, a significant minority, haven't seen their GP for a year or more.
yeah.
And they've just been living on badly with their seizures. So it's not great, if that makes
No,
sense.
it's pretty awful. And I would say if people need the extra push, do it for the sake of people that like you and love you. Because even if you are feeling depressed, as many, we know about the high suicide rate of those with epilepsy as well, and even the high rate of depression in love members. Do it for people that care about you. And if you don't think they care about you, they probably do. You're just feeling bad if you think they don't.
I would just add an extra line to it, is that actually make people aware of the risk. Because I think lots of people out there would be willing to change their lifestyle, but they think, oh, SUDEP is not for me because my epilepsy is well controlled. And whenever I hear that word well controlled, I always question, is that what you had, say, when you first had a seizure, to now 20 years later? Think back a bit and see, is it really well controlled? So it's that.
Totally. I spoke to a gentleman recently who told me that his seizures were completely controlled. He was smoking weed every day, using epilepsy as an excuse. I'm like, yeah, dude, whatever. It's his choice, but it wasn't for his epilepsy. And he'd chosen to just come off his AEDs overnight, and said, yeah, no, I have no seizures. And then I found out after our talk that he was having seizures, but he just completely lied about it. Now, I don't know if this poor man was in denial, he was ashamed of it or what, but I just thought he is one of a squillion people out there that are going through that, and they don't, and then I think we need to reassure them, if you've got a good neurologist, neuropsychiatrist, they're not going to judge you. They'll just say, okay, let's work around this because we want you to exist and we want you to live a good life.
Yeah.
Not die.
And I think that's where we have to bring our human adaptability a bit, because we settle very well into new normals. If you think about it, like COVID now, we sort of get used to a new normal. We are all ready to have.
I like my plants.
Exactly. To Sainsbury, we'll have social distancing. We suddenly become, we adapt ourselves, and we can adapt ourselves negatively too. We get adapted to new normals in conflict. So that's also a challenge. And one of the big things is, research has shown that many people actually miss knowing about their seizures. So
oh gosh, yeah.
EEGs have shown that attacks haven't been captured by people because they haven't been aware of it. And I think that itself should be a matter of concern.
Totally. And I can speak even from a patient perspective, my memory's so pants, and especially if I've gone and had I mean, I'm very lucky now. I have very few tonic-clonics, maybe one a year-ish. But even like the other types of seizures, say I fall asleep right afterwards, then I might forget that it's happened. Or like you were talking about before, nocturnal seizures, you don't know that's happened either. And that's obviously a really, really risky time for SUDEP. And so, yeah, it's no disrespect to people with epilepsy, but I think sometimes the diary doesn't give, that they provide, that we provide rather, doesn't necessarily give all the useful data to the neurologist, right?
Yeah, you're only as good as we are only as good as the information we get from the cold face. So it's like if somebody comes and says we've not had any seizures, well, I'm not going to go around asking for more work, am I, by trying to make 100 to find out whether you had a seizure or not. It's like I'll take the people on their face value and their word. I mean, most people want to come and see you and want to tell the best things, but is that it? I mean, it's so there is a lot of rigmarole in and a challenge in how do we actually get to the diagnostics of it. But equally, I think safety first, and it is important to, in one sense, it's a bit like wearing the mask. We should presume that there is a potential of harm here. I mean, if I get COVID, I would hope that I won't even feel the symptoms. Many don't, but I would still want to wear a mask, won't I? I mean, it's the same thing. If we are at risk, we should wear a mask, wear Epsilon, get your checks done. So that's what I would say. So
yeah, they seem like simple things. It's just trying to convince people, I think. And yeah, I just seriously, I used to be at such high risk of SUDEP. It was ridiculous. I didn't even know back then. I had no idea before I got to Queen Square. I was, just so depressed and having so many seizures, and I was just trying to get on with it. And so there are so many people out there, and I just want them to, if you feel that you can't talk to your neurologist or your epilepsy nurse, we'll try. And if you can't, it's okay to ask for another one that you might get on with. And because
I
priority
think,
of you.
If people use Epsilon, obviously I've got a potential conflict of interest, but I don't make any, as you know, it's totally free and
Yes. Pay nothing, just download it.
Yeah. And nobody makes any money out of it. It's run by charity. But I think one of the big thing which is there is that if people are, why would people be afraid of meeting a neurologist or a health professional, is because they feel that they might come across as ignorant, or basically they might show themselves down. That's where Epsilon helps to help quantify risk, because also no sensible clinician will actually turn a patient away if they are seeing black and white that A, B, C, D, E are the risks. We are in the job of wanting to make a difference. So my colleagues, I'm sure, I mean, you know them, many of them, and they're all very passionate people who just want to make a difference. So.
Yeah. Aww. So if people want to know more about you and what you do, where should we point them?
More like, I guess, heavenwards, I hope, but
we've got you on Twitter. There's lots about you people Google.
Yeah, Twitter would be a good place, I guess, if anybody wants to be in touch. And I've got a university page, and it's something which can be linked up there. So
okay, well, I'll put links under the YouTube, because if you're okay with it, I'll put this on YouTube.
Yeah, it should be fine.
La-di-da you, yeah. So and I've said this in other videos today, but us lot often forget a lot of things, so it's good to have the video there to remind us, and we can watch it again, you know.
And I think you're doing a really incredible thing here, but also there's a lot of information which I think people have to take in, and it's better done. I mean, people might want to choose it in bite size to get that through and to again revisit it. So
yeah, so you can revisit this video. Also check out SUDEP Action. That's a really good website as well.
I think they have been one of in the forefront. I mean, all the charities, national charities, have been incredibly brilliant in their way in which they showcase stuff. But SUDEP Action, obviously, the very theme of SUDEP is something which they brought up and have made sure that it's hits out at the highest political level. But also one of the interesting and very important thing is their learning journey also takes into account epilepsy deaths, and they run the national register for epilepsy deaths, so that if say something unfortunate does happen, clinicians, families can refer in and we can learn, so that our learning journey continues. I mean, none of the SUDEP checklist would have actually come up if we hadn't actually learned about various factors of death and what happened. It's unfortunate, but at least it made it meaningful for the people who sadly went.
Yeah, exactly. But I think we're ending on a positive note, though, and the positive thing is that the more you are aware of your own neural activity, there are many different ways to record seizures or try and record them, and find a great neurologist, and know that you're not alone in any worries that you might have about SUDEP as well.
Yeah.
The information is out there for you, and we will put the links on the YouTube channel too.
It's sort of like treat it with respect, the epilepsy, because it can harm you. I mean, that, as I said, it's like a car. Car gets you to places, you live with it, but it can also kill you. So epilepsy is the same. Treat it with respect, give it the sort of conditioning that it wants, the MOT it wants, and at regular intervals, and keep safe. That's the main thing.
Indeed. Thank you so much. Thanks for your time, Rohit. Take care. Don't Rohit will blog for us at some point as well. And
yes, I've actually written half of it, and then I got hijacked by the COVID. Yeah, I have. I have written. It's sort of a bit of a poignant story, not my usual typical flamboyant, what you call a sarcastic humor one, but yeah.
Oh, if I want to laugh, I just call you. Amazing. Thank you. All right. Take care of yourself and your family.
Thanks for the opportunity. Bye.
Bye.